In terms of the treatment of non-small cell lung cancer over the past 5 to 10 years, the landscape has changed very substantially. We've gone from a situation where we really only needed to know whether it was non-small cell lung cancer or small cell lung cancer, to us having much higher demands of our pathology colleagues. So we now not only need to know what particular histological subtype of non-small cell lung cancer is it, so that we can decide what chemotherapy we need to use, but also we need to know what the molecular status is. We need to have sufficient tissue to be able to determine whether they have an EGFR activating mutation, to find out whether they have an ALK gene rearrangement, and now most recently whether they have PD-L1 expression at a sufficient level for that to impact our initial treatment plan. So there's been major changes in the way that we diagnose lung cancer, because that need for all of that testing means that we need to have more tissue. And this is something that has been fed out into our chest physician colleagues, who often are at the diagnostic end. So they're now very much aware from our MDT discussions that we need to have sufficient tissue to be able to determine what the specific type of lung cancer is, so that we can make the right treatment decision. In terms of how the landscape has changed, it makes a fundamental difference to a patient whether they have a molecular subtype of lung cancer compared to what you might call a standard non-small cell lung cancer. Because if you have an EGFR mutation, then our initial treatment is not with chemotherapy, it's with an EGFR TKI. And actually we're now in a landscape where we know about mechanisms of resistance to EGFR TKIs, in particular T790M. And osimertinib is a drug that's been developed specifically to overcome T790M resistance to first-line EGFR TKIs. And the studies that have been done of osimertinib have demonstrated substantial improvements in progression-free survival, improvement in response rate, improvement of quality of life. And we have yet to see whether those benefits will translate into substantial overall survival benefit. It's always difficult to demonstrate overall survival benefit, because in the studies there's crossover, so patients can access the new treatment. But that has made a substantial change, because osimertinib is now the standard second-line treatment for patients that develop T790M. That's another molecular change, and of course we need to look for molecular change, so we're back to the situation where we need to have tissue or DNA to be able to detect that change. T790M is not the only mechanism of resistance mechanism of developing resistance for patients that are on EGFR TKIs. There are other changes that can develop. Occasionally there can be small cell lung cancer transformation, and there can be other mechanisms of resistance such as HER2, MET skipping mutations, etc. So we are looking in repeat biopsies for other mechanisms of resistance. It's not always possible to obtain a repeat biopsy in patients. So the other really important finding from the AURA3 study, which looked at the role of osimertinib compared to chemotherapy in patients who'd already received an EGFR TKI, was looking at the role of ctDNA to pick up the T790M. So looking at whether we could detect T790M from the blood of patients rather than biopsy, and then looking at the outcomes in those patient groups. And essentially that showed that we could detect T790M in the blood of the patients that had it in the biopsies mostly, and that the outcomes were consistent for those that we had T790M in the biopsies. So that's important for us, because we now know that yes, if we can get a biopsy, we do get a biopsy, because of course there are other mechanisms of resistance that we might treat in a different way, but it also means that we can take blood to look for T790M, particularly in patients for whom it's difficult to obtain another biopsy. So that really has again led to a change in our practice, where we need to be proactively looking for T790M and doing more repeat biopsies than we've ever done in the past.